to go. This is Barbara Cochran. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center. You're not going to see me. I'm just speaking into my computer Zoom. But I'm really happy to welcome you again. And I think this is the third to the last lecture for this series. Just a reminder to check in with your site coordinators for evaluation forms if you haven't filled out a profile form for the series. This series is ending for spring term in a couple of weeks, and then it won't be offered again until winter term, hopefully if we'll have funding. So just stay tuned for information about that. Today, I'm very, very happy to introduce to you Dr. Gregory Gardner. He's a professor in the Department of Medicine's Division of Rheumatology and an adjunct professor of orthopedics and sports medicine and rehabilitation medicine. He's board certified in both internal medicine and the specialty of rheumatology, specifically connective tissue disease. He's a fellow of the American College of Physicians, and Dr. Gardner is an expert in treating and managing inflammatory arthritis and osteonecrosis. He's also interested in providing training for medical students and primary care physicians to improve arthritis management. So he is the perfect person to talk to us today about arthritis in the older adults. Welcome, Dr. Gardner.
It's a pleasure to be here. I've spoken of this series in the past and grateful for the opportunity to come back and share some more thoughts with you. Here's the outline of things we're going to talk about today. We're going to talk about common rheumatologic issues in senior adults. We'll talk about a case-based format. I'll present a sort of a typical case prior to discussing each one of these entities. We'll discuss the role of various healthcare providers that work together as a team to help our patients do the best they can. And then we'll have enough time for questions and answers as well. You don't think about arthritis as being as impactful as some other diseases like diabetes or, say, heart disease, but it's a very common problem in this country. You can see the numbers are growing as we're growing older, including myself, in terms of our population in the United States. The numbers of people affected by a musculoskeletal condition will also increase and will impact our healthcare system and our national budget as well. And it is equal to heart disease as a source of activity limitation, and probably will become even more so in the coming years. Women are twice as likely as a man to report some sort of limitation from arthritis. And there's data here about low income versus higher income. And again, for our lower income patients, it tends to be more impactful for those in higher incomes, often because jobs are affected by the arthritic condition. And lots of us, as we get older, we expect to have aches and pains, and so we don't seek help for some of the problems that could be helped if addressed. So here's the things we're going to talk about today. Osteoarthritis, which is by far and away the most common form of arthritis that you and I deal with in seniors. Fibromyalgia we think about as being a younger group, but it actually is very common in older adults. Rheumatoid arthritis has, as we will learn, two peaks: younger women and then older men and women after the age of 60. Gout often occurs because of increasing size of our population, not numbers, but actually size, super size, and also medications that seniors get to treat hypertension and other conditions. And finally, there's a condition that we see uniquely in older adults called polymyalgia rheumatica, and I'll explain what that is in a few minutes. So the healthcare team we're going to talk about is physician, the nurse practitioner, surgeon, PA, nursing, nutrition, pharmacist, OT, PT, social work. All these have a role in helping our older adults with these conditions. I've also given you some resources you can go to find out more information, and also to provide some really great information to patients who have these conditions. The bottom one in particular, American College of Rheumatology, has a patient-focused site and has all kinds of information about medications as well as the diseases we're going to talk about that you can hand to patients and help them understand more about them. And also the Arthritis Foundation has some great resources as well, and also some patient-focused programs that can help people with these conditions. Before we talk about the specific conditions, let me give away a few rheumatology pearls. There are only 3 basic patterns to joint disease. And I use these every single day in my career. So the first one is inflammatory. Inflammatory forms of arthritis typically cause 30 minutes or more of stiffness in the morning. Think about rheumatoid arthritis. People wake up and they're very stiff, sometimes up for a couple of hours. They feel better as long as they get up and move around. Swelling is common in the joints. And polymyalgia rheumatica and rheumatoid arthritis are classic examples of inflammatory forms of arthritis. And then osteoarthritis is considered a mechanical form of arthritis. There is some mild inflammation that's there, but in general, people complain about 10 or 15 minutes of stiffness in the morning. And when they use the affected joint, they have more pain. And then osteoarthritis and tendonitis are classic examples of mechanical forms of arthritis. And then finally, fibromyalgia. People with fibromyalgia say, I'm stiff in the morning for an hour or two. I'm achy and fatigued through the day. And if I overdo it or exercise too much, I pay for it for a couple days. They often feel like they have the flu or they've just been wiped out and have to be in bed for a day or two. People with fibromyalgia often have other somatic issues like chronic headaches, chronic low back pain, TMJ, other sorts of things that they have to contend with in addition to the fibromyalgia, which is pain and fatigue. Let me give you an example of the first thing we're going to talk about. This is a classic presentation of somebody with osteoarthritis. A 70-year-old woman with 8 months of progressive right groin pain. Now, the groin is important because a patient with hip pain, patient also will say, my hip hurts, and they'll point to the outside of their hip. That's almost always soft tissue pain. Somebody says the pain comes from my groin, we're thinking hip joint pain. She's having trouble putting on stockings on the right side because she can't flex her hip very well. Her pain is 6 or 7 out of 10. Ibuprofen takes it down to a 3 or 4. On examination, she has reduced internal rotation and extension of the right hip. This is a classic example of somebody who's presenting to us with osteoarthritis of the hip joint. So osteoarthritis is by far and away the most common form of arthritis that we see in clinic. Upwards of 60 million adults have osteoarthritis, either clinically and or radiographically and or clinically. Some people have x-ray changes but don't have a lot of pain. Women are affected more than men, as mentioned earlier. The prevalence increases with age. The older we are, the more cartilage we tend to wear out, and the more osteoarthritis we get. The causes of osteoarthritis are really interesting. So we know that genes can control the quality of our cartilage, and if it's not quite up to par, it can wear out more easily and lead to osteoarthritis. Some people are born with abnormally shaped joints, particularly the hip joint, in which case that leads to early osteoarthritis. Weight is an important issue for a lot of lower extremity joints in general developing osteoarthritis. There's a 4 times rule I think is important to remember. Every time we weight bear across our hip and our knee, we concentrate 4 times body weight across those small surfaces. So if we are 20 pounds overweight, that's 80 extra pounds the hip or the knee sees with each step. Likewise, if you lose 20 pounds, that's 80 pounds not seen with each step by those joints. Trauma, a previously traumatized joint, is more likely to develop osteoarthritis as well. This is really fascinating. This is the inside of a joint through an arthroscope. This is courtesy of one of my colleagues in orthopedics, Roger Larson. This is the normal looking knee. You can see look on the top of the slide, that's the femur. Down below, that's the tibia. And that little linear thing in the middle, that's the meniscus. That's hopefully how all our knees look. Here's early osteoarthritis of the knee. Everything looks a little bit thicker. That's because the cartilage is fibrillated and it's swollen. And then here's somebody with more advanced osteoarthritis where you see bare areas of the bone. Can't see it very well, I apologize. And the cartilage is in tatters. That's advanced osteoarthritis. Currently, there's no regenerative way to come backwards. I know one of the hot topics in medicine these days is regenerative medicine. People are looking for ways of helping to regrow cartilage, but that's still in the future. Some of the symptoms of osteoarthritis include, we talked about that stiffness in the morning, that's 5 or 10 minutes, pain with use. You can get you can get deformity of the joints, and I'll show you some examples in a minute. And you also get gelling. You sit for a while, you get up, you're stiff a little bit, and you have to move around in order to get that joint to work again. Here's classic osteoarthritis of the hands. I want you to note which joints are involved as well. As it turns out, the DIP joints, or the distal interphalangeal joint, the joint on the end of the finger, is often involved, as is the next joint called the PIP, or the proximal interphalangeal joints. The MCPs are those knuckles that are at the beginning of the fingers, for some reason, are not affected by osteoarthritis, except in certain cases. The base of the thumb also is quite commonly affected. It's called the CMC joint, and it can affect your ability to pinch and to grasp. So when I go into a room and see the DIPs, the PIPs, and the base of thumb affected, I know exactly what the patient has. And it takes you, and hopefully it'll take you in the future as you get good at looking at hands, 30 seconds to make a diagnosis of osteoarthritis. Here also is some x-rays, and hope you can see those from the distance. So let me show you a close-up just to show you more, a better view. So what happens in osteoarthritis is you get what are called osteophytes, or excess bone formation around a joint, as illustrated here. Let's go back. In this picture, you also see the joint space is narrowed. Here's a more normal DIP joint. You can see these two are quite abnormal. There's also some narrowing here in the PIP joints, although not quite as severe as those DIP joints. Let me show you some examples of osteoarthritis in the hip. There's lots of osteophytes, of those bone spurs. There's cysts. There's loss of cartilage here, and this is a painful hip. If somebody walks on this, it would be uncomfortable. Also on this knee, you see the bones are touching here because of the loss of cartilage, and there's some osteophytes out here as well. This is, again, a mechanical form of arthritis. Your bone on bone is not a good way to bear weight, and it's not particularly very comfortable either. How do we approach osteoarthritis? Well, we in rheumatology like to think about pyramids a lot. It was more popular in the years past. But in terms of, there's lots of things that can be done that don't require medications or surgery that really can have an impact on people with osteoarthritis. Let me share some of those with you. This is the 2012 American College of Rheumatology suggested non-pharmacologic therapy of osteoarthritis. And strongly recommended are aerobic or resistance land-based exercise. We'll talk about the benefits of exercise in just a minute. Aquatic exercise can also be done for those who have some limitation to land-based exercise. It takes the weight off the joints. If somebody's large and needs exercise in the water, so you can reduce that impact of weight. You can also lose weight. We talked about the 4 times rule. Self-management programs are helpful. And you think about why that might be. Somebody who knows what they have to expect is better able to deal with that. Taping the patella to make sure it's aligned can be helpful. There are some wedges you can put in your shoes to help with the alignment abnormalities of the knee. Walking aids like a cane can offload your joint by about 25% if used correctly. For example, if I have osteoarthritis in my left knee, what side do I use the cane in? Most people would say left. But a therapist or somebody who knows about osteoarthritis and knows about these would use it in the opposite hand. And it sometimes takes a visit or two to a therapist to make sure the cane is correctly sized and is correctly used by somebody who needs that. A walker can also be used to help stabilize people and give them confidence back that they can be outside and walk. And finally, there's also evidence that Tai Chi helps people both with the pain and with the balance issues that may be affected by osteoarthritis. Knee braces are sort of plus minus. Some of them may be helpful for patients or expensive, and probably are limited to certain patients who are relatively slim and don't have really advanced osteoarthritis of the knee. How about medications? What is recommended for treatment of osteoarthritis? Acetaminophen can be used. There's some long-acting forms of acetaminophen arthritis. That's how they're marketed. They last approximately 8 hours. 650 milligrams, 2 or 3 times a day could be used to help people with arthritis. Topical NSAIDs, especially for people over the age of 75, have been shown to work as well. There's only one topical NSAID on the market in the United States. It's diclofenac. In Europe and other places, there are many more topical NSAIDs that could be used. But there is data to suggest that it actually works pretty well and is relatively safe as well. Oral NSAIDs are a little bit more tricky because of the comorbid conditions our patients over the age of 60 might have. But they can also be used in lower doses. Tramadol has been found to be effective. It's a low-potency narcotic. I tend to use it in small doses or for rescue medication when there's no other options. Corticosteroid injections can also be used. Not recommended in general is glucosamine, chondroitin, or topical capsaicin. But I have patients who tell me that it works pretty well for them, and I'm not going to argue with them. So glucosamine and chondroitin, they're relatively cheap. They're relatively safe. And at one point, they were felt to be effective, particularly if the studies were done by the companies that made the drug. Publicly funded trials didn't show a lot of benefit. But again, if a patient wants to try that and there's no other contraindications to their use, I say go ahead with it. I do have to share one of my thoughts about treating osteoarthritis, and that is, in osteoarthritis, you do not want to get rid of the pain completely. Why is that? Well, think about if you have an abnormal joint that's biomechanically abnormal and you have no pain in it, what would you do on it? Whatever you felt like, right? That's what I would do. So somebody has a biomechanically abnormal joint. It's important for them to have a little bit of memory pain, as far as my philosophy is concerned, to remind them that they can't do some of the things that they otherwise would do and further damage the joint. There are a lot of reasons why people don't exercise. And this is from Basha Belza, who was one of the faculty members of the School of Nursing here at the University of Washington. So the main reason is pain, although that's why we want to get people to exercise. Fatigue, weather, particularly true here in Seattle. Motivation, no time, no access, no buddy. A lot of times having a buddy is a motivating factor for exercise, as you know. Injury, cost, transportation. In general, people with arthritis are less aerobically fit than other people, especially when lower extremities are involved. As it turns out, they can exercise just fine when done so in a prescripted way. And having our physical therapists give us some help can often get them fit. And as we know, people who are aerobically fit have much less pain in general. We also know that exercise, if done properly, does not make arthritis worse. And sometimes being involved in a group itself has benefits. So here's some more benefits of exercise. Aerobic fitness can, again, reduce pain scores. It can improve muscle flexibility and strength. Actually, depression and anxiety scores go down when somebody's aerobically fit. And cardiovascular mortality is higher in people with osteoarthritis and goes down with those who are aerobically fit. Osteoporosis is often treated by weight-bearing exercise. And I learned this from my nursing colleagues, self-efficacy. What the heck is that? Self-efficacy is having confidence that you can do something. And so if you're physically fit or you're working with a group of people who have the same thing you do, and you see them doing things, you get a little bit more interest or less anxiety about doing it. So self-efficacy is very important for helping people to stay as active and healthy as possible. This is the study done, presented at one of our national meetings. This is intensive diet and exercise therapy for osteoarthritis of the knee. It was an 18-month study, and they took groups of people, a pretty good-sized group, and they either exercised them 30 minutes 3 times a week and 20 minutes of weight training. They worked on getting their diets to help them lose 10% of their body weight, or they combined those two things. And as it turns out, as you can imagine, the best outcomes are people who did both. So weight reduction was higher in the people who exercised and focused on weight loss. Pain scores, look at that. Pain improved 51% over baseline, people who exercised and lost weight. Speed of walk improved, and overall function improved as well. It also improved for the diet and exercise groups alone, but the combination was really impressively as good as any kind of medication I can think of giving patients with osteoarthritis. This is a little bit older study, but it was a review of topical NSAIDs for various forms of pain. And they compared the data to people who were taking oral NSAIDs. And in general, they again felt they would be as effective as the oral medications for things that were more superficial, knees, fingers, toes. Didn't work that well for large areas like back pain or those sort of things. And again, I use it in patients who have poor problems with their kidneys or are on anticoagulants. You can use it because it doesn't really achieve much of a blood level and can give the patient quite a bit of relief. And then finally, surgical intervention. For patients who have uncontrolled pain, they can't, the quality of their life is going down in spite of all we do and all we've talked about. Age 65 to 85, typically a slender build and good health, they can do great with the surgery. And it really has taken people from rocking chairs to cruise ships. So it's one of the great advances in medicine in the last 50 years is total joint arthroplasty. I'm going to say a word about first MTP, metatarsal phalangeal osteoarthritis, which is also very common. It's the first joint, your big toe, the first joint before it becomes a toe. And this x-ray is showing you these big osteophytes coming off. They can be quite uncomfortable as you try to walk. There are some things that can be done to help mitigate that pain. You can use things I talked about already, NSAIDs, topical NSAIDs, capsaicin cream, glucosamine, chondroitin, injections. Get a wide toe box shoe with a rocker bottom. I'm showing you a picture of what that is down on the bottom. So a good running shoe, as you walk, it tilts in response to your walking, and your toe doesn't have to bend. So it takes the pressure off your toe when you have a good rocker bottom sole. You can also wear a regular shoe with a graphite insert that makes it very, very stiff. Again, your toe doesn't have to bend. You walk a little stiff foot, but again, it takes the pressure off that first MTP. And avoid activities that make it worse. For example, swim and bike rather than run. And then you can do surgery. And this is a picture of somebody who has bad first MTP osteoarthritis. And somebody's had surgery. There's a plate put across there so the toe doesn't move. So it becomes a little stiff, in which case a graphite insert or a rocker bottom sole is even more important. But it also takes away the pain. Let's talk about the role of the healthcare team in somebody with osteoarthritis. We talk a lot about what physicians and PAs and nurse practitioners can do, but nursing can provide educational materials, make sure medication compliance, monitor for side effects. Nutrition, again, weight loss is critical in patients who are overweight to try to reduce progression and also reduce pain. Let me tell you an interesting story. I had a woman one time, she was only in her late 50s, had really bad osteoarthritis of her knees. She was about 260 pounds and her BMI was about 35 or 36. I gave her my usual, lecture about weight loss and arthritis. This wonderful lady actually took it to heart. She got in the pool and she started swimming on almost a daily basis. She lost 85 or 90 pounds. And I had sent her to the surgeon before, and the surgeon said, you got to wait till you lose some weight. got to have a BMI of 30 or less before we'll operate on you. So she achieved that. And when she talked to the surgeon goes, okay, we're ready to replace your knees. And she said, I don't need surgery now. My knees feel so much better. And so they were able to put off the surgery because of that exercise and pain control and weight loss and pain control made a huge difference in this lady's life. All right, I think we're going to wait. We're going to move on. We're waiting to we'll wait for questions till the end. Let's move on and talk about this condition. 68-year-old woman complains of 1 year of diffuse muscle and joint pain. Has been to multiple care providers without an explanation of her symptoms. She's fatigued in the morning and after any significant activity. Her husband died 2 years ago. She sleeps very poorly, wakes up frequently during the night, rarely goes out with friends anymore because of the way she feels. On examination, she's occasionally tearful with describing her situation. No signs of joint swelling or muscle weakness, tentative touch in various muscles. Lab work is normal. What does this lady have? She has fibromyalgia. But look at this history. Again, as you think about this lady, she lost her husband 2 years ago, probably used to having him around to close up the doors at night and other sorts of things. So she probably doesn't sleep very well because she's probably, every little noise probably wakes her up. And she looks like she's depressed as well. Not going out with friends, she's tearful, she talks about her situation. So, just think about, again, the whole patient as we think about. I've been impressed that nurses tend to focus on patients. Physicians tend to focus on diseases. And hopefully, as I grow up, I'll be more like nurses and think more about patients and diseases sort of secondarily. Fibromyalgia is relatively common. It's 3.4% of women, and 0.5% of men. Peak age is 25 to 45, but occurs at any age. Many people can have a mood disorder in conjunction with the widespread pain and fatigue. And we mentioned there's a lot of coexisting illnesses as well. Then here's the classic symptoms we've sort of talked about already. Here's a little diagram of, I think more people recognize fibromyalgia now than they used to. But here's what often happens. People go to the healthcare provider, and they describe their symptoms. All the blood tests are normal. The provider goes, I'm not sure what you got. And so that worries the patient, that they think they may have something serious or unusual. They seek another opinion. Again, the same thing happens. And so it just becomes frustrating for the patient. So being able to recognize fibromyalgia, and hopefully what we've talked about and those symptoms I've discussed with you today, will be helpful for you to recognize it. What causes fibromyalgia? Well, we know that you can actually experimentally induce fibromyalgia in test subjects by interfering with their stage 4 sleep. This was done in medical students years ago. And if you don't let them go into a stage 4 sleep by watching their EEG patterns and then intervening in some way to wake them up just a little bit, you can develop fibromyalgia. People are generally deconditioned. They tend to avoid things that can be most helpful for them, which is exercise. And we'll talk about how that should be done. There may be some neuroendocrine abnormalities as well. As I mentioned, people tend to be either have anxiety or depression. So there may be some neurochemicals that are out of balance. Of interest, some research I did years ago with a gentleman named Ed Walker, a psychiatrist, found that not an insubstantial percentage of people who have fibromyalgia will have a very difficult childhood history or have a PTSD-like event in their life. And also maybe other psychological factors, including often from the family of origin. So how do we approach people with fibromyalgia? Well, our job as clinicians is to confirm the diagnosis and rule out mimics. I'll show you some of the blood tests I typically get to make sure nothing else is going on in the patient. But generally, we have to address three things: sleep disorder, deconditioning, and distress. So sleep, this lady, maybe what she needs is to move to an independent living facility where she would feel comfortable in the night. maybe she needs, make sure she shouldn't have sleep apnea, because that can cause stage 4 sleep disorder as well. Occasionally some medications. I use very little Ambien anymore, but a low-dose TCA or some Benadryl can sometimes help get people to sleep, or some melatonin. Deconditioning is very, very important. I've never seen anybody with fibromyalgia in 30 years as a rheumatologist get better who has not exercised or stretched. But it's got to be done very slowly and progressively. I've had patients tell me, you know, doc, I can't even walk out to the mailbox, 50 yards away. I say, well, go halfway out to the mailbox every day for a week and then come back. Second week, walk to the mailbox and come back. Third week, do it twice. Fourth week, walk the end of the block and come back. So again, think about 6 months from now. I want you to think about, by doing that progressively, how much you have achieved, even though you may still have some aches and pains. You'll be doing so much better functionally. And then distress. Again, victimization issues, mood disorder. Keep people active and involved in life. Don't let them retreat, because they tend to do worse when they retreat from feeling productive and feeling part of life. There are some medications that can be used that are approved for treatment of fibromyalgia. Pregabalin or Lyrica, duloxetine or Cymbalta, milnacipran or Savella. The first is a anti-seizure medication. The last two are SNRIs for treatment of depression. Again, they seem to have that pathway in particular seems to be very important for the development of fibromyalgia pain. The SSRIs don't seem to be very effective. So here's some of the labs I would check. A blood count, look for inflammation, make sure the kidneys are working okay, there's no abnormalities of liver tests, make sure there's no hypothyroidism or hyperthyroidism. Vitamin D levels can be checked, especially in the Northwest here. Osteomalacia can cause bone pain. If the patient is weak, I will get a CK. Hepatitis C, I'm sort of plus minus about. But I've seen some hepatitis C patients present as fibromyalgia, and that's why I put it on there. I do avoid checking antinuclear antibody tests or rheumatoid factors or CCPs without a really good history or an exam that sort of suggests there's an underlying autoimmune inflammatory disease. Just because I've seen patients with classic fibromyalgia treated for lupus, their lupus test was a low positive without any corroborating evidence, but treated nonetheless with moderate doses of prednisone for a long period of time when they actually just had fibromyalgia. So be careful about not giving people the diagnosis of lupus without really being sure that's correct. So let me show you some things. I think this is very helpful as I think about how I approach people with fibromyalgia. Here's my job. I confirm the diagnosis, I rule out mimics, provide counseling, maybe referral to a counselor or a social worker if I think that's necessary. I use medication sparingly because there's no medicine that is that dramatically beneficial for fibromyalgia. I recognize the limitations of my therapy and try to make sure I get the patient involved in their own care. What's the patient's job? Well, the patient hopefully will continue to work or volunteer, maybe with a little modified schedule, take medications as suggested, get some psychological help if needed, stretch, exercise progressively. I put those all in capitals just to emphasize the importance of such. And also recognize the limitation of medical therapy, including the perils of taking opiates. There's been no study that I've seen that have shown people with fibromyalgia benefit from taking opiates. Now, occasionally I do provide patients with a small supply if they feel that it's quite helpful, or occasionally some tramadol. But again, the medicines aren't going to cure the patient. I have seen some patients exercise their fibromyalgia away though. So again, what the patient does is really more important than what you and I can do. I love this, this picture. This is not the way they exercise. I suspect these guys probably spent $100 on the gym, and they should just be walking up and down the stairs. They would have saved a lot of money. Anyway, so exercise is key. And also, again, this goes along with my contention about nurses. It's more important to know what sort of a patient has a disease and what sort of a disease a patient has, especially in the context of fibromyalgia. What about the role of the healthcare team? Again, nursing, educational materials, discuss issues of pacing and monitor medication use. Nutrition, discuss dietary issues, weight loss if needed, avoid fads. There's all kinds of diets out there that purport to, to treat fibromyalgia or whatever you got. So just be careful about going on some of those type of diets, because sometimes they can be a bit dangerous. The pharmacist can medication compliance and interactions. Sometimes these patients are on, polypharmacy. As a clinician, I try to get them off some of those medications and rely more on their own self-efficacy, exercise, etc. PT, OT also are critical for these patients to help them learn how to exercise in a slowly progressive way, to pace themselves, and to keep going. Social work also can be critical for people with fibromyalgia in terms of work issues, family issues, maybe some in-depth counseling that can help them get over some of these things. I had a patient, when we did this study with Dr. Walker years ago, I had a woman who I invited to participate in the study. We looked at fibromyalgia and rheumatoid arthritis patients. And one of my rheumatoid arthritis patients who had a lot more pain than I could ascribe to her disease, I asked her to participate on the rheumatoid arthritis side and I described what the whole thing was about. And she said, I really don't want to participate. I spent so many years burying those bad memories that I don't want to bring them up again. And I felt so sorry for her, because it's almost like an abscess, If you uncover that stuff and get it out, people get healthier. But sometimes there's a lot of pain in doing that. So I can understand her hesitancy. All right, let's move on to the next thing we're going to talk about. This is a 58-year-old artist complains of pain and stiffness in the morning and for the past 5 months. He's having increasing difficulty squeezing his paints and holding his brushes. He's noticed swelling of the joints of his hands and of his feet. On examination, he did have swelling of the small joints of his hands, his wrists, his knees, and the joints of the feet on both sides. This is classic presentation of rheumatoid arthritis. And I'll show you why I picked an artist in a second here. It's inflammatory autoimmune disease. It affects actually the number is a little bit less than this. More recent numbers suggest 0.5 to 1% of the population, which is still a big chunk of people. If you have a first-degree relative with rheumatoid arthritis, your risk is double that. So it goes up to 1 to 2%. So still not very high. Like a lot of autoimmune diseases, women are affected 3 times as men are. And it occurs, as I mentioned, during childbearing years. But after the age of 60, both men and women get it equally. Some more information about rheumatoid arthritis. Again, the inflammatory pattern. It's polyarthritis, which means 6 or more joints are affected. Laboratory tests are quite helpful. Here's the joints, just emphasize this again, that are affected in rheumatoid arthritis. It's the wrists, the MCPs, the PIPs, and for some darn reason, the DIP joints, or those distal joints, the end joints, are spared in rheumatoid arthritis. They're not affected. There's a clue to the diagnosis there and understanding of the disease that we haven't figured out yet. Here's somebody with very, very early rheumatoid arthritis. I don't know if you can see on the camera and other sites, but if you look at your own, if you look at the skin folds over your middle joints, your PIP joints, they should be nice and loose. If you see the middle and fourth finger on this person, they're a little tight, indicating that there's fluid in the joint. Here's a little more obvious case where somebody's got a PIP swelling. In this case, the MCPs, or the closest to the wrist there, joints, are swollen as well. And here's somebody with advanced rheumatoid arthritis and has what's called subluxed, meaning the joints are out of place, and they're ulnar deviated, meaning the hands curl towards the outside of the hand, towards the ulnar bone, and that hand's not very functional. Let me share with you a little bit of art. This is called The Luncheon of the Boating Party by Pierre-Auguste Renoir, painted in 1881. The woman in the foreground in the lovely hat with the dog is Eileen Charigot, who was his favorite model at the time. And they later got married and had 3 sons together. You'll see her in many of the pictures. If you're a Renoir fan, you'll see her in many of his pictures. Here is Renoir in 1896. You can't see much, but look in let's go back. Look in 1901. You can see his hands here are swollen. Look how small his thighs are because he's got swollen knees. He's got rheumatoid arthritis. He developed very severe rheumatoid arthritis. And in spite of that, a few years later, he paints his family. This person over here is a friend of the family. These are his two little sons. This is, I believe, is Jean or Pierre. And this may be, I can't remember what his name is. This is our housekeeper who actually was a model for Renoir as well. Back then, it was the style to dress little boys like little girls while they were little toddlers. Anyway, let me show you this next picture. You'll see a dramatic transformation in his hands in just a few years. Here he has those classic subluxed, ulnar deviated hands, typical of rheumatoid arthritis. And in the next picture, 1911, he's in a wheelchair. That's how he gets around. His hands are markedly deformed, but he continues to paint. He needs to do what he loves. And here's his beloved Aileen just before she passed away with, again, a little dog. And here's Renoir painting about that same time. He puts the brushes between his fingers and continues to paint. I love talking about self-efficacy. This is what Renoir says. He says, the pain passes, but the beauty remains. He painted as a form of therapy. An amazing story of resilience of the human spirit in spite of chronic disease. We talked about the hands. The feet are also affected. You get fibular deviation. The toes go towards the fibular bone, and they also cock up because of subluxation, out of place joints. Here's the bottom of the foot. You get these bad calluses down there because that's where all the pressure is. Radiographically, you see on the thumb there, you see a little rat bite. It gets worse. Those two middle joints are quite eroded, those two MCPs, the second and third. And then here's a gentleman I showed you earlier. Clinically, the bones are washed out, the joints are subluxed and ulnar deviated, and this is a very dysfunctional hand. Besides the joints, rheumatoid arthritis also can affect other parts of your body as well. It can affect the lungs, the eyes. It can give you what's called rheumatoid vasculitis. You can get some horrible cases of carpal tunnel, as illustrated by the loss of the muscles here in the hand. You can get parotid involvement and get a secondary Sjogren's syndrome. In fact, some of the driest patients I have are not Sjogren's patients, they're actually rheumatoid arthritis patients. Some of the laboratory tests are helpful. People are often anemic. Sedimentation rate, or CRP, can be elevated, indicating inflammation in the body. Rheumatoid factor and CCP are often quite helpful for the diagnosis as well. Rheumatoid factor is an antibody that's directed against the patient's own IgG. And it occurs in a variety of chronic diseases, including Sjogren's, lupus, hepatitis C, cirrhosis, lung inflammation. So it's not specific to rheumatoid arthritis, but can be seen in other conditions as well. The next test, called the anti-CCP, isn't in a high level. It is quite helpful for making a diagnosis of rheumatoid arthritis. Let's see, get to my slides here. There we go. So the other thing about the CCP that's very important is that it can be present for up to 14 years before you develop your rheumatoid arthritis. Let me show you a picture. This is in 1989. And this handsome guy back here is me. I actually had hair back then. And
I think our slides get out. They're not showing up on mine. Sorry, I'll just be a second. Sorry about this, by the way.
no problem.
That shouldn't do it. I'll just slide this over. Sorry for the interruption.
No, thank you. Thanks for your help. So as I mentioned, this is me in 1989. And 1989 was a landmark year for rheumatoid arthritis, not because I graduated as a fellow, but because things were happening. This is what I learned how to take care of rheumatoid arthritis. I learned that if you have rheumatoid arthritis, you started off with some physical therapy, some education, that's all good stuff. Then you put them on some aspirin, sometimes up to 16 aspirin a day. If that didn't make things get better, then you'd use some low toxicity disease modifying agents. If that didn't work, you use some higher toxicity agents, often needed surgery about this time, and finally, when all that failed, you ended up going back to rehabilitation again. We now know that that was probably not the right way to go. Now, the reason being is that back then, most people had erosions or damage to their joints within the first 2 years of disease. Disability was common. Few people achieved any kind of lasting remission in spite of the medications available at the time. And of interest, if you had rheumatoid arthritis in 1980s and you were a woman, you would lose 10 years off your life. And if you were a male, you lost 4 years off your life. And the most common cause of early death in rheumatoid arthritis was not the disease, not the medications, it was plain old-fashioned heart disease. We know that any time you have an active inflammatory disease that's not well controlled, you accelerate atherosclerosis and get early heart attacks. And that's been true for rheumatoid arthritis for many, many years until recently. So in 1989, things changed. People recognized that we need to be a little more aggressive. We need to treat people up front aggressively to prevent the inflammation from causing the damage to the joints. And along with that philosophy change, some new medications started to come out as well. I love this quote from Irv Kushner. He says, what we need in rheumatoid arthritis is a drug for which one does not need a statistician to see the beneficial effects. We needed our patients to tell us that things worked. And in that, we now have those kinds of drugs. The other thing that's happened is we now do what's called treat the target. So we actually measure clinical responses in our patients every time they come in. And we grade them on how well they're doing. If they have moderate or high disease activity, we change their therapy in some way in order to get them down into remission or low disease activity. And here are all the medications that are available to treat rheumatoid arthritis these days. I only had a few of those back when I was a fellow 30 years ago. I've got all kinds of great medications now. And often in combination with methotrexate, they have a huge impact on inflammation and disease course. So here's how we treat rheumatoid arthritis in 2019. We treat as, in fact, the first time you come in, if you got rheumatoid arthritis, you're getting on methotrexate. And then we increase the dose and we watch your response. We have some tools like ultrasound. We can look inside the joint to see how you're doing. If you're not doing well, we add more medications to your joint, to your regimen, until we reach that low disease or remission status. And again, it's absolutely amazing the outcomes of some of our patients these days. People with poor prognosis include people who have nodules or eye disease or other extra-articular manifestations or have high levels of rheumatoid factor or CCP. I won't spend a long time on this. This is, again, people have this paradigm for approaching rheumatoid arthritis. This has been updated, although it really became more confusing rather than less confusing. But I can tell you, in 2019, many fewer people go on disability. They have much fewer extracurricular or extra-articular things like nodules or eye disease. Mortality rates are dramatically down. In fact, they're not quite at general population levels, but they're getting pretty close. I tell my patients now, you'll never know how sick you could be. So here's 1980s. This was the outcome for rheumatoid arthritis. Here's the outcome in 2019. That's what people are doing these days who have rheumatoid arthritis, which, you know, warms my heart as a physician. Again, it's been really gratifying to be a physician during that whole transition period. And we're getting better. We now get about 50% of patients into a remission and 80% don't have any progression of their x-rays. With time, we're going to get even better. Those coming what's called proteomics and genomics, we'll be able to actually do precision medicine. We'll be able to test your blood, know which genes are activated, and give you the appropriate medication rather right now than sort of guessing which one to give you next. This would be great. What about the healthcare team? Nursing, education materials, medication compliance, very important. Side effects, key. Administer medications in many cases, infusions. Prior authorization of expensive medications, nutritionists, low-fat diet, vitamin supplements. Rheumatoid arthritis is a risk factor for osteoporosis. The pharmacist also key to making sure no interactions and proper strengths of medications. OT, PT, less important than the old days when people were getting disabled very quickly, but still maintaining strength, range of motion, aerobic activity, key, and then social work, helping to make sure our patients get insured. If there are disability issues or work-related issues, they can be modified, great. And then occasionally surgery needs to be done, and financial issues around that can be helped by a social worker. All right, we're getting close to the end here. I want to tell you about this next patient. This is getting to be more common than it used to be. And I'll tell you why in just a minute. Here's a 67-year-old gentleman complains of pain in the base of the first toe every few months. Pain gets so bad he cannot walk on the toe, and it gets red and swollen. It lasts about a week and then goes away. If he uses Aleve, it'll go away sooner. He used to drink heavily and still has 2 beers a day. He's on hydrochlorothiazide for his hypertension. He's got these white bumps on his ears and nodules on his elbows. There's no swelling today. So this is the gout. My patients in North Carolina used to call it the gouch. I thought that was very appropriate because it is one of the most painful forms of arthritis that I take care of. One of the most painful things patients have to go through in general. So the characteristic of the gout attack is severe pain, redness, warmth. It loves the cool places of the body, like the toes and the ankle in particular. And here's a little, I think, 18th century drawing of what they visualized was associated with the gout. Here's a little devil coming out of Hades to gnaw on your foot in the middle of the night, because it is very, very painful. We know the first attack of gout comes after many years of having high uric acid in your blood. The first MTP, or the big toe, is involved in most patients. It's really rare in women before menopause, unless a woman is very, very much overweight. If you have high serum uric acid levels, you're more likely to get tophi, or collections of uric acid on cool places of your body. Diuretics are known to increase uric acid levels and also can contribute to the development of gout. And as it turns out, uric acid levels may go down a little bit during an acute attack. So we usually wait till the attack is over. If we think it's gout, we'll check your uric acid after the attack to get a baseline level. There's some great therapies for gout these days. So we often use either anti-inflammatories. We can use systemic corticosteroids. You have to use at least 35 milligrams a day for about 5 to 7 days to get a benefit. Colchicine can be used if used early. It's a very toxic drug, and if you don't have a lot of experience with colchicine, I would recommend using either NSAIDs, like Aleve, 2 tablets twice a day, or systemic corticosteroids, 35 milligrams a day for 5 to 7 days. You can use ice to reduce some of the pain. And in most cases, that will break the attack. I've listed here some of the other medications that can cause hyperuricemia, or high uric acids. The diuretics, niacin, which we use for high triglycerides. Calcium urine inhibitors are often seen in people who have had transplants done. Low-dose aspirin, which sometimes is necessary, although more recent evidence, as you know or may have heard, low-dose aspirin is probably less effective or less useful for preventing heart disease and strokes than it used to be. There are some medications that are helpful, actually. Vitamin C will lower uric acid, a drug called losartan for blood pressure. I think it's been taken off the market now because of the risk of cancer. Statins and some dairy products actually will lower uric acid levels. So we tend to avoid certain medications if we can, avoid beers and ales. They're the worst offenders for hyperuricemia in terms of food. Slow weight loss, people who go through crash diets, uric acid levels go way up. A low purine diet is typically one low in red meat, low in shellfish, low in organ meats, and one low in beers and ales. So there are medications we can use to lower uric acid. One's called allopurinol, the other is called febuxostat. They work really well, but they have to be started slow and worked up slowly. Excuse me. We often put people on a little bit of colchicine before we put them on one of these medications to lower uric acid, because we know you've been storing uric acid for years in your tissues. And if we give you medication to lower serum uric acid, you start mobilizing all that uric acid you've been storing for years, and you get more gout attacks. So we give people a little bit of colchicine, if they can tolerate it, a few days before we start their allopurinol, then put them on the allopurinol, and then increase it slowly until we get a patient down to a uric acid between 4 and 6 milligrams per DL. Again, here's some guidelines for treating gout. Again, number 3 is what I want to emphasize. Treat the target. We are focused on getting uric acid as rheumatologists down between 4 and 6 milligrams per DL. And we leave the colchicine on for about 6 weeks. And after that, patients can just stay on their medications. The other thing I want to emphasize is not only do we keep people on these uric acid lowering drugs to prevent gout, there's been recent evidence that people with high uric acids are at increased risk of cardiac mortality increase if they have heart disease. If you already have some damage to your kidneys, high uric acids can accelerate the loss of the kidneys. So there's some other reasons to consider having people stay on their allopurinol or their febuxostat for a long, long time. People often take their medication, and when they feel good, they stop them. But in this case, they can't do that because the uric acid will just come back and they'll get gout again. Here are some of those tophi. It loves elbows, it loves ears, it loves DIP joints, the fingertips, and you can see how enlarged that finger is. The crystals look sort of like this. I don't know if you can see it from the back. They're long, thin needles, and when you put them under a polarized, compensated microscope, they look either yellow or blue, depending on how they're oriented to the microscope. This is an impressive case of gout. This is bad gout. Somebody with tophi in the hand. And the picture of the foot there shows you how destructive it can be. So the bone has been obliterated by the chronic low-grade inflammation of having tophi around those bones. Here's something really, this is one of my favorite pictures of success in medicine. Here's somebody with tophaceous gout. Look at that. That looks horrible, doesn't it? So how do you get rid of all that? How do you get rid of those tophi? Well, you put them on allopurinol. You slowly titrate it up until their uric acid is really low. And then look what happens. So it can be done, but it takes patients' willingness to stay on the medication, that slow titration, that lowering uric acid to a low level. It can be done. And the gout and the team, nursing again, education materials, compliance with medications, key, side effects, arrange for visits with acute attacks or give them advice about how to deal with an acute attack. Pharmacists can also do that as well. At Harborview, there actually is a pharmacist-directed gout program where the pharmacist actually helps titrate the medication up and monitors uric acid levels, and it works great. Nutritionists, again, we're talking about low purine diets. They can't not take some purines in. It's just too hard not to do that. Pharmacists, medication compliance and interactions, and social workers, again, some work issues, alcohol issues, if they're there, need to be some counseling for, etc. All right, last but not least. This is, again, the unique condition for people who are seniors that I see not uncommonly, because it often affects people of Northern European descent. In fact, it's very rare among African Americans or Asians. We have a lot of Scandinavians and Northern Europeans in the Seattle area, so we see quite a bit of this. Here's a 70-year-old woman who complains of 2 months of AM stiffness in the shoulders. Began something, this lady can remember the day that symptoms began. She couldn't get out of bed. She had to roll herself out of bed. She was so stiff. She had a diagnosis of bursitis made, and she got a steroid injection, and she felt great all over for about a week, and then it all came back. On examination, she has some mild global reduction of range of motion of her shoulders, otherwise normal. She also noticed that her hips have gotten stiff as well, around her thighs and her buttocks. Those are getting stiff just like the shoulders were. Here's the consensus criteria for the diagnosis of polymyalgia rheumatica. Typically age greater than 50, bilateral shoulder or pelvic girdle pain, duration more than 2 weeks, stiffness more than 45 minutes, sedimentation rate or CRP are invariably elevated, often quite high. And these patients have a rapid response to low-dose prednisone. My practice is to split the dose up initially. So if somebody comes in, I think about polymyalgia rheumatica, PMR, I give them 10 in the morning of prednisone and 2.5 at dinner time. And on that, I tell people about the KISS sign. I say, you're going to feel so much better tomorrow. You want to come back and give me a big kiss. And somebody actually brought me a bag of Hershey's Kisses. I thought that was kind of nice. But it is a really rapidly responsive condition to low-dose prednisone. So some of the clinical features of polymyalgia rheumatica we've discussed already. Some people can actually have some swelling of the joints. The more recent criteria say that's not the case, that you probably have seronegative rheumatoid arthritis. Carpal tunnel can occur in about 20% of people. And here's a distribution of the stiffness. Again, this is primarily stiffness. So neck, shoulders, down to your arms, hips and thighs. And again, one of the classic history points is patients say, I have to roll myself out of bed because I'm so darn stiff. What's nice about treating polymyalgia rheumatica, here I put on here 50 milligrams, sometimes I use 12.5 milligrams. And then once you respond, we leave you on the dose for about 4 to 6 weeks and then begin tapering prednisone, try to get as low as we can. Sometimes if people relapse and can't get off the steroids, we use some methotrexate or some flutamide, or a newer agent called tocilizumab, which is an IL-6 inhibitor, works really well as well. I do have to tell you about an associated condition with PMR, and that is what's called giant cell arteritis. About 10% of people who have PMR will develop giant cell arteritis. So you always have to have your ears and eyes open, because this can be much more devastating. So people who have PMR are at risk for this condition, which is inflammation of the arteries going to the brain and to the eyes. It's a cause of blindness. And when I was an intern in medicine, I remember having a patient who had symptoms of headache, some visual changes, jaw pain when she chewed, didn't seek any medical attention, came in one day blind in both eyes because it causes inflammation of the ophthalmic artery. And she had it on both sides. So the criteria are age over 50, high SED rate, new headache, often with scalp tenderness. And this, I'll show you a picture of somebody with an enlarged artery there. You can get jaw pain when you chew. It often may take you an hour to eat your meal. Or you get visual blurring, or you lose vision that comes back. That's a worrisome sign that somebody might have giant cell arteritis. And you can get this without having PMR. So again, anybody over the age of 50 or so with a new onset headache and any of those other symptoms I mentioned should be evaluated for possible GCA. A sedimentation rate over 50 is often seen as well. And here's that picture I described to you with the enlarged temporal artery because of inflammation. That's tender too if you palpate it. For GCA, or giant cell arteritis, we use high doses of steroids, 40 to 60 milligrams a day, and then begin a slow taper. Osteoporosis is a concern in these patients, and luckily we have a new therapy for it. It's called, again, the tocilizumab or Actimra. It's given either IV or sub-Q and works dramatically well for these patients. So there's a new therapy out for temporal arteritis or giant cell arteritis. All right, in conclusion, musculoskeletal problems are common in older adults. I didn't actually talk to you about shoulder pain from rotator cuff disease or tendonitis, those sort of things. There's lots of other things that occur. These are the inflammatory, well, mostly the osteoarthritis is not inflammatory, nor fibromyalgia, but these are some of the major things a rheumatologist sees in clinic. Again, recognizing them, treating them appropriately can really impact the quality of life of our patients. And a lot of people, the healthcare team can get involved to help manage these conditions and really improve life quality and outcomes for people with these diseases. All right, I have time to take some questions. Barb?
And I don't have any coming in yet, so if there's questions here in the room.
The topical NSAIDs, is that an over-the-counter drug?
So the question is, are the topical NSAIDs over-the-counter drug? In Europe, they are. Probably in Canada, they are. In Mexico, but not here. They come in, the diclofenac comes in between 1 and 3% gel. And it actually is still fairly expensive, even though I think it may be generic. But it is by prescription only. Any other questions?
Don't have any coming in. Folks, do you have any other questions? Very clear presentation.
I guess so. Either I put everybody to sleep and they're just... Okay, well, thank you for your attention, and hopefully this is helpful to you. And oh, we've got one question.
But I'll see if we can get that connected. Oh, I didn't disconnect the recording. Looks like we're good now.
Okay, so the question is, why wasn't there fibromyalgia 40 years ago? Well, there was. It just wasn't recognized. Over the years, people have had all kinds of different somatic illnesses that have been labeled different things, and I'm sure it was fibromyalgia. They just called it something different. So yeah, there's fibromyalgia 40 years ago, just called something different.
And another fibromyalgia question is, what would abnormal lab levels be for fibromyalgia? Are there any?
So a question about abnormal levels for fibromyalgia, they would be normal. That would be the point. So the reason you're doing the labs is looking for something else besides fibromyalgia to describe their symptoms. So think about somebody with hypothyroidism. What are they going to complain about? They're going to complain about fatigue. They're talking about weight gain, about sleeping too much, and they're just going to feel kind of lousy. My sister actually developed hypothyroidism after one of her babies, and she just felt horribly fatigued and achy all the time. She sort of mimicked fibromyalgia. That's why you're doing those things. You're looking for other things that would explain how they feel besides fibromyalgia. So again, you're trying to rule out mimics of fibromyalgia. Don't forget about sleep apnea in particular that can cause sleep disturbance and cause symptoms that may be very similar to fibromyalgia, or maybe fibromyalgia.
And then a question actually about the sort of common wisdom, whether one's crackling their knuckles actually causes arthritis.
So crackling your knuckles simply bothers your mother. It doesn't have anything to do with arthritis. It's actually of interest is you're taking nitrogen out of solution and making it into a gas. That's what you do when you crack. That's why you can't crack your knuckles over and over again. You have to wait until nitrogen goes back into solution. My colleague Peter Simkin taught me that. So yeah, if moms out there, if you want to say that it causes arthritis, fine, because it bothers you, but it doesn't really cause arthritis.
And now I think we're at the end. That looks like the last of the questions, other than a comment that this was an excellent, excellent presentation.
Thank you again for your attention.
Very much.